Hi, folks. In this lecture, we're going to look at material from Chapter 17, which focuses on stress, anxiety, and neurodevelopmental disorders. First, let's define what stress is. We formally define stress as a physiological reaction, so something that you feel within your body, something that your body itself is actually doing in reaction to some perception you may have of an aversive or threatening situation. This type of response is caused by your perception of that event as being either threatening to you or just really unpleasant. And what results from this is kind of the fight or flight response that we talk about a fair bit when we talk about how we react when we feel particularly stressed out, threatened, or just scared. We have, two choices: we fight that, or we flight, we flee. We say that this is a species typical response because this type of response will look different depending upon the species that you are interested in. And again, this is a very much an evolved biological reaction to the feelings of being in a threatening situation. And again, it's just that fight, so stay and deal with it, or flee the situation or remove yourself from the situation. If we look at the internal happenings behind stress, so what's going on inside of your body when you're feeling that stress response, that fight or flight response? The sympathetic branch of your autonomic nervous system, so this is the branch that is kind of active when you feel a heightened sense of awareness, like a stress reaction. So that is the sympathetic branch, whereas the parasympathetic branch is more of the calming side of things. So bringing you back to rest after being in a heightened sense of awareness and having your sympathetic branch be active. So during stress, the sympathetic branch of the autonomic nervous system is active, and your adrenal glands are secreting epinephrine, norepinephrine, and steroid stress hormones. Epinephrine affects glucose metabolism. So basically what this means is that it's allowing glucose to stay present in your system and not be broken down, because it's possible if you're going to have to fight, you need something to run your muscles, and that would be glucose. So epinephrine affects your ability to metabolize glucose and makes it to where you have more available, so you can essentially fight or get out of a strenuous situation. So you can basically perform the way that you need to. Here we're looking at a grouping of hormones that are particularly of relevance when we're looking at the body's stress response. The first one we'll look at are the glucocorticoids. These are a group of hormones in your adrenal cortex that are particularly important when we're looking at both protein and carbohydrate metabolism. We also find that these seem to be especially present or secreted in your body in times of high stress. Next, we'll look at CRH for short, or the corticotropin releasing hormone. This is a hypothalamic hormone. So in your hypothalamus, so a hypothalamic hormone that stimulates your anterior pituitary gland to secrete what is called ACTH for short, or the adrenocorticotropic hormone. So it's essentially stimulating your pituitary gland to secrete another hormone. And that hormone, again, ACTH for short, is a hormone that is released by your pituitary gland in response to the CRH. And this in turn then stimulates more production of glucocorticoids. So it's kind of a cyclical process. Here we look at the CRH hormone a bit more closely. This is, again, a hormone that's secreted within your brain, highly tied in with stress, like we just looked at the previous slide. We believe this hormone serves as a kind of a neuromodulator, or maybe even neurotransmitter, especially within the limbic system, which is really highly involved in your more emotional responses. And this seems to be kind of what it might be behind the more behavioral effects that look similar to those that are produced when you are in aversive situations. So this seems to be highly tied into how you respond um, emotionally during high stress events and also behaviorally perhaps as well. Now, this is kind of a two-sided thing here. This particular hormone, um, again, triggers the release of glucocorticoids. The short-term effect of that is good. It's kind of essential for our survival. If you can't have an appropriate level of attentiveness and ability to deal with a stressful situation, then you're not going to survive very long. So, the presence of these quote stress hormones is quite good in the short term. However, if they're in your body in abundance on a more long-term basis, the effects can be quite damaging. Here, for example, we look at stress and the levels of hypertension over the course of years in a high stress job. This particular study was looking at pilots, and we're looking at age on the x-axis and hypertension or high blood pressure on the y-axis. And what we'll see here is it doesn't really matter whether or not, first of all, you're working in a more, low stress or a high stress airport. It seems as though, as a function of age or exposure to the job, all pilots experience a higher likelihood of becoming hypertensive as they age. It does seem as though the pilots that were frequenting more high stress airports were more likely to see hypertension um, at a bit of an earlier onset and just more likely in general. You can see the pilots that were working in the high stress airport in orange here. So again, we see the same trend overall with the high stress and low stress airports, but it does seem as though the folks that were working at the high stress airport were experiencing levels of hypertension at a higher rate than those in the lower stress environments. So again, this is just kind of just one example of how we can see that over time, the effects of being in a very stressful situation, one that probably has increased your level of stress hormones over the course of a longer period of your life, it is more likely that you're going to have more severe health effects due to that long-term exposure. Here is one particular researcher that looked more closely into these more harmful effects of stress or prolonged exposure or prolonged secretion of glucocorticoids. And they found that these were just some of the things that were tied into having these higher levels of glucocorticoids for prolonged periods. That includes hypertension, like we just looked at, but also diabetes, infertility, inhibition of growth, damage to muscle tissue, inflammatory responses throughout the body, and also a suppressed immune system. If you check your book chapter closer, there's a whole chunk of this chapter just looking at the impacts of stress on your immune system, but also just your immune response in general. Your ability to deal with exposure to really anything seems to be greatly impacted if you have prolonged exposure to stress hormones. Next, we move on to PTSD, or post-traumatic stress disorder. We basically say that this is a development of a characteristic grouping of symptoms that follows an exposure to one or more traumatic events. This can be a cumulative effect. So basically, the more traumatic events you experience, the more likely it is that you are going to have some form of PTSD. And just to add a bit more to this, although men are exposed to traumatic events more often than women, it does seem like women are more likely to develop PTSD. We can talk about this in terms of maybe the types of trauma that men versus women may be more likely to experience. That could be one possible reason behind this, but it does seem as though men, while exposed to more traumatic events, are less likely to experience PTSD when compared to women. The common symptoms associated with PTSD could be recollections of the traumatic event, as well as recurrent dreams about that event, and also reports of intense psychological stress. There have been some studies looking into the heritability of PTSD, both in terms of genetics and environment, and I think that it's really important to consider both. Um, it is possible that perhaps somebody with PTSD may have some physiological differences, and that could result in more struggle with dealing with traumatic events. And perhaps their physiological differences could be heritable. So if they were to produce offspring, they could pass those traits down to their offspring. So that is possible. But also, environment, I think, is very much key. If you think about it, if you are born into an environment where someone is experiencing PTSD and they exhibit behaviors that go along with PTSD, then it is more likely that perhaps you may also be more susceptible to experience PTSD. It does seem like that there is some overlap between PTSD and anxiety disorders. And we do find that folks that have been diagnosed with PTSD, it does seem as though what neurotransmitter system is more likely to be kind of impacted is the dopamine system, in particular the D2 receptor sites and transporter sites. Most common treatments for folks with PTSD include cognitive behavioral therapy, or CBT for short. This is a popular therapy. It basically is, in layman's terms, trying to change how someone perceives something and help them perceive it in a way that's a bit more manageable. Um, there's also group therapy as well as antidepressants. Combination of perhaps all three of these could be helpful for some individuals. Next, we move on to anxiety disorders. We can formally define anxiety disorder as being really tied into an overactivity of the autonomic nervous system. So this is going to involve things like increased respiration, dry mouth, increased heart rate, etc. A lot of body tension. Folks that have some sort of diagnosed anxiety disorder tend to report things like expecting something horrific to happen, some impending disaster, and maybe they're like continually trying to prepare themselves for that impending disaster. Relatedly, panic disorder, this is tied in with kind of episodes or periods of symptoms that are tied into shortness of breath, the irregularity of heartbeat, things like that, usually accompanied by intense fear. Also relatedly, anticipatory anxiety. This is really tied into the fear that you might have a panic attack. Not that you had one, but that you could have one. This could also lead potentially to agoraphobia. And agoraphobia is a fear of being away from your home or your safe place, or just some protected place. It could be your car, wherever it is. It's some place that you're familiar with that feels like a safe space to you. Agoraphobia is a fear of being removed from that. A lot of times we see folks that report that they're just basically scared to be out in public. So public spaces, of being away from their private protected space. Um, Then there is also just the more generalized anxiety disorder. So this is just characterized by just excessive anxiety or worry. And it could be generalized to anything. But basically, if you struggle with this, you're worried about everything, basically all the time, to the point that it's disruptive to your life, and it could be also disruptive to other people's lives around you. And then there is social anxiety disorder. So this is when we are being overly concerned or have an excessive fear of being essentially exposed or scrutinized by other people. And it gets to the point where you avoid social situations because you are afraid of being essentially judged and assessed by other people. Here we take a look at panic disorder, agoraphobia, generalized anxiety disorder, and social anxiety disorder. And we're kind of comparing and contrasting each of these and seeing kind of where the overlap is versus where the difference are. Some treatments for anxiety disorder. In general, it seems as though SSRIs are quite a popular treatment for anxiety disorders because it is generally believed that the serotonin system, is what is being affected when we're looking at anxiety disorders. So SSRIs, such as fluvoxamine, may be given to somebody with an anxiety disorder. Um, there's also quite a bit of interest in GABA receptors for folks with anxiety disorder. If you remember from when we were learning about neurotransmitters, GABA is an inhibitory neurotransmitter. Basically, that is a calming neurotransmitter. It's meant to kind of chill you out. Well, um, with anxiety disorders, it could be the GABA receptors, or essentially the GABA system, being inhibited. So the release of GABA, which is inhibitory and calming, the release of that is being inhibited. So benzodiazepines have been looked at as another treatment, or maybe in combination with SSRI treatments for anxiety disorders. Here we're looking at the effectiveness of fluvoxamine, which is an SSRI. And we're looking at this over the course of weeks, and we're looking at average number of panic attacks. Fluvoxamine treated patients are in orange, placebo patients are in blue. It does look like that maybe perhaps the fluvoxamine is helping a bit, particularly by week 8. It does look like there is a difference between those folks and the folks that had placebo. So perhaps this particular SSRI may have a positive effect for folks that have an anxiety disorder. Here we're looking at benzodiazepine use. So if you look at the far right of the receptor site here, we're looking at the benzodiazepine site. And it seems as though we're not really sure how this works, but it does seem as though when benzodiazepines are present, they bind to the site, the receptor site, and it seems as though that enhances the GABA system. So benzodiazepines essentially are a GABA agonist. So when someone is given benzodiazepine, it seems as though it helps their GABA system be more productive, or that their GABA sites are being able to release GABA into the system, which is again a calming or inhibiting neurotransmitter. That is going to be helpful in reducing heart rate and things like that. Next, we look at OCD for short, or obsessive compulsive disorder. This is defined as a mental disorder characterized by both obsessions and compulsions. Obsessions are defined as unwanted thoughts, okay, unwanted. Thoughts or ideas in which a person becomes extremely preoccupied. That is, they are so distracted by these thoughts and ideas. And again, these are unwanted thoughts or ideas. And also, the other part of OCD is the compulsion, which is the feeling that one is obligated to perform some kind of behavior, even if they don't want to. This could be tapping, knocking, jumping, anything like that. Perhaps it's a certain number of times, a certain number of alternations from left and right and back and forth. But it is, again, a compulsion. Someone feels like they have to do it to the point that they feel as though something horrible is going to happen, perhaps, if they don't engage in that behavior. The drug treatment for OCD seems to be more focused on the serotonin system, in particular drugs like fluoxetine, fluvoxamine, and clomipramine. So these are really going to be more specific to blocking the reuptake of serotonin. So really, we think about these as being serotonergic agonists. So enhancing the serotonin system. This seems to be helpful for some people with an OCD diagnosis. Next, we look at autism spectrum disorder, or ASD for short. This is referred to as a chronic disorder. So essentially, this is going to be something that someone will live with throughout the course of their life. This is not something that can be, quote, cured. We tend to think about autism as being like the hallmark symptom is a failure to develop normally or typically in a social way. So social relationships with other people seem to be very impacted for folks that have ASD. In particular, we see impairment of the development of communication. So the ability to communicate can be verbal. A lot of times it is verbal, but it can be other forms of communication as well. In more severe cases, we might see what we call stereopathy, or repetitive stereotyped movements, or repeated movements, ones they do over and over again, that they're distracted by and paying way more attention to that than they are the people around them. There has been research into the heritability of ASD, and it does seem when we look at monozygotic twins, there is concordance in monozygotic twins, meaning that if one twin has it, the other twin is very likely to have it as well. Up to 70 to 90% of monozygotic twins, if one has ASD, the other one has it as well. If we look at biological causes, so prenatal exposures to things that could potentially be dangerous, such as rubella, that could make it more likely that the offspring or the child would have autism spectrum. Again, ASD is really kind of defined as a communication and social disorder, right? We might see folks with this, again, that have limited behaviors, that they're, we say limited or repetitive. So repetitive meaning if they're into it, they'll do it over and over and over again. But also limited in the sense that they're only interested in a very limited amount of things. This is a very common thing amongst individuals with ASD. They have a limited interest. So for example, if they're into cars, for example, that's all they're interested in and that's all they want to talk about. If they're going to talk at all, that's what they want to talk about. That's what they want to focus on. They're not interested in learning anything else. Symptoms are present in childhood. 2 years old is still the earliest that a child can be tested for ASD. The symptoms do seem to be present at a very, very early age. If we look at brain changes in ASD people, we see significant developmental abnormalities. In particular, we have newer MRI studies looking at brain differences, and something that's been observed has been an abnormal rapid growth period between 2 to 3 years for ASD patients. But then after that, their brains slow and seem to grow slower in relation to unaffected children or children that do not have an ASD diagnosis. They also have observed the amygdala following a similar pattern of development as well. Also, differential brain growth in areas that are highly tied in with communication and also just interpretation of social stimulation. So things in our environment, I'm highly involved with things like other people or conspecifics. That's another fancy word for another individual of your species. But interpretation of things in the environment that are more social in nature, there seems to be a difference in the areas that seem tied to processing those type of stimuli between typically developing children and ASD children. There also seems to be a difference in what we call theory of mind, or being able to guess intentions. So theory of mind is basically knowing what somebody else knows or assuming that somebody else is going to do something because of some reason. So I might assume that you are going to the bathroom because you need to use the bathroom. That is an assumption that I make. But it's because I have some kind of theory in mind or some kind of view into your brain, and I know, it's highly likely if you're going to the bathroom that you're going to use the bathroom, right? Somebody with autism spectrum is going to struggle with stuff like that, knowing the intentions behind someone's actions. Why did somebody behave the way that they did? Why did they go where they went? Children and also adults with ASD do seem to struggle a bit with this idea of theory of mind. And lastly, we see normal activation early on in the visual association cortex. However, activation in the superior temporal sulcus or the STS and the medial prefrontal cortex is much slower among people with autism. Here we're taking a look at ADHD, or attention deficit hyperactivity disorder, not to be confused with ADD, which is attention deficit disorder. They are not the same. One involves the hyperactivity component, which is what we're looking at here. The other one does not. So ADHD is characterized by uninhibited responses. So just inability to control oneself, lack of sustained attention, so you can't pay attention for a very long time, and also the hyperactivity component. So it's the most common behavior disorder that first appears in childhood. So it's something that is diagnosed typically in children. So it's a little bit less common for somebody to be diagnosed with ADHD as an adult. We've looked into the heritability of ADHD. And it does seem as though there's some strong evidence for both family studies and twin studies for the heritability factors that seem to play a role in somebody developing ADHD. The estimated heritability of ADHD is particularly high, between 75 to 91% by certain researchers. Here we have a table from your book just looking more closely at symptoms that somebody with ADHD might struggle with. Again, we're looking at a persistent pattern of inattention in correspondence with hyperactivity or impulsivity that really affects what we would call optimum functioning. We have the inattention component as well. So in addition to hyperactivity, we have decreased attention when it's important to pay attention. We're having issues doing so. Also, in particular, having struggles with attending to details, maybe more of an increase in making kind of careless mistakes, difficulty following directions or being organized. The hyperactivity component, again, if we're looking at that and the impulsivity aspects as well, we could be looking at, if a child is in school, them squirming in their chair a lot, they leave their chair a lot and run around, they climb when it's inappropriate, they may talk too much, etc. Lastly, we look at brain changes that can be associated with ADHD patients. There have been reports of a decreased brain volume in total, such that it may resemble those produced by damage to the prefrontal cortex. And this could be correlated with the behaviors that we view, such as distractibility, forgetfulness, poor planning, impulsivity, and hyperactivity. We can also see damage to the prefrontal cortex, which could be tied into issues with working memory. And lastly, there has been suggestions that just perhaps it is an issue with the dopamine system, in particular with the dopamine system being underactive. And maybe if we were to treat that it might help folks with ADHD. And it does seem like with a moderate dose, we see increased responsiveness of the prefrontal cortex, and also moderate doses might increase dopamine and norepinephrine in the prefrontal cortex. So it does seem like we have some support for the idea that the dopamine system is heavily tied into issues with ADHD.